Hello, Kinesiology 3030. Welcome to our lecture on the lower appendage, our first lecture, which will cover the hip and the knee. So first off, we've already talked about the upper extremities. We've talked about the trunk and the neck. Now we're moving down inferiorly across the body down to the pelvis and the lower extremities. So when we look at the reason why, or the kind of the purpose behind the lower extremity, first, they're used as a way to stand upright. Humans are an upright creature, and how we position our lower extremity can influence our posture or what's going to happen above the pelvis based on pelvic position. We also use it for locomotion, or kind of walking, getting around, moving around. We're bipedal organisms, so we walk on two legs, and those two legs are our lower extremity. And lastly, we use them for things like defense, striking, using them as an additional tool to protect ourselves. Besides just getting ourselves around, standing upright, we also may need to use these extremities as defense tools when we're in some kind of conflict. Because we do have larger lower extremities compared to our upper extremities, we can apply more force. We can hopefully defend ourselves to a greater extent. So what are some movements that we have available at our lower extremity? First, we have the movements at our hip joint, or our iliofemoral joint, also known as the acetabulo-femoral joint or coxofemoral joint. We know this is a ball and socket joint, which allows motion in all three planes. So we have sagittal plane movements, flexion and extension, frontal plane movements, abduction and adduction, and transverse plane motions, inward and outward rotation, or internal and external rotation, in other terms. We'll also talk today about the tibiofemoral joint, or the knee joint. We'll talk about how it is a modified hinge joint, so it allows flexion and extension with slight rotation that occurs throughout that flexion extension, that tibial rotation that occurs with our knee movements. We'll get a little deeper into that. So let's start looking at the pelvis. The pelvis also can move in space. The pelvis is really our center point, but depending on how the lower extremity is positioned and the upper extremities and the thorax are positioned, it can tilt and move the pelvis out of this neutral position that we think of it as kind of this standard bowl that's right in the center of our body. It can tilt in different directions based on what's going on above and below that pelvis. So we have pelvic tilts, both anterior and posterior, left and right in the transverse plane. So we have sagittal plane, frontal plane, and transverse plane pelvic tilts. These are not joint movements. These are structured positions, or looking at how the pelvis itself is moving in space, regardless of what is happening below or at the joints above. This is where the pelvis is positioned in space. So we'll get more into these into labs, but an anterior pelvic tilt is when the pubic symphysis moves inferiorly. Posterior pelvic tilt, where the pubic symphysis right at the most anterior point on the pelvis. Posterior pelvic tilt, our pubic symphysis moves superiorly. So think about it as the pelvis being this bowl. Anterior pelvic tilt, we dump forward. Posterior pelvic tilt, we dump backwards. With our left and right lateral rotations, or lateral pelvic tilts, right lateral pelvic tilt is when the left side moves superiorly and the right side moves inferiorly, but in the frontal plane. And left is the opposite. Left lateral pelvic tilt, the right side moves superiorly and the left side moves inferiorly in the frontal plane. So think of it as kind of the steering wheel is attached to your sacrum. And if you turn that wheel to the left, it's a left lateral pelvic tilt. If you turn that wheel to the right, it's a right lateral pelvic tilt. So think of it as kind of like the steering wheel going up and down, up and down. When we look at this in the transverse plane, we just shift that steering wheel down to the center, move it into the transverse plane like a bus steering wheel. If you turn that wheel to the right, it's a right pelvic rotation. If you turn it to the left, it's a left pelvic rotation, transverse plane rotation. I like to use the term tilt for frontal plane and sagittal plane, and then rotation for transverse plane, because we like to synonymize transverse plane and the term rotation. So anterior and posterior pelvic tilt, right and left, lateral pelvic tilt, and then left and right transverse plane rotations of the pelvis. These are all pelvic positions, which will influence iliofemoral positions as well as lumbar positions. But we'll get more into that when we can get some physicality when we're talking in class. So let's move into those muscles of the lower extremity now that we have kind of this basis of why we have the lower extremity. These muscles are often biarticular. Many of our lower extremity muscles cross multiple joints as a way to help transfer forces throughout locomotion. Applying forces at different joints can allow us to move more efficiently, as well as with higher rates of speed. They're also layered, superficial, and deep. More superficial muscles are often larger in the lower extremity. Deep muscles are often smaller in size. Superficial muscles are often gross movers, or they create these large movements, and deep muscles often are stabilizers and allow for more fine control of the lower extremity. So let's start off. First muscle we'll discuss is the gluteus maximus. Gluteus maximus is our largest hip extensor. It's our prime mover for hip extension. It has an origin on the sacrum and the ilium, so it's this medial origin, posterior on the pelvis, and then an insertion on the greater trochanter and the fascia lata, or the IT band, the iliotibial band. So gluteus maximus really does cross the hip joint primarily, and it does attach to some connective tissue that does cross the knee joint. It does not allow for motions at the knee. It is primarily a iliofemoral mover, or a hip joint mover. So its actions are really only at the hip. Its actions are hip extension, hip horizontal abduction, hip external rotation, and then it can contribute to a posterior pelvic tilt. So if the femur is locked down, so think about these pelvic tilts really in closed chain activities where the feet are planted on the ground, so you're standing upright. If you contract gluteus maximus, it's not going to move the femur posterior, it's going to pull yourself into hip extension, but by moving the pelvis into a posterior pelvic tilt. We'll get into more details and physically feeling that in class. We look at the other two gluteal muscles, because we have three gluteal muscles, gluteus maximus, gluteus medius, and gluteus minimus. Gluteus medius and gluteus minimus both have origins on the ilium. Gluteus medius has a superior origin on the ilium, and gluteus minimus an inferior origin on the ilium, and then they both insert on the greater trochanter. So they have a similar position to gluteus maximus. However, gluteus maximus has a more posterior and medial origin site, as opposed to medius and minimus, which have more lateral origin sites. The actions here are hip abduction. And when we're in a closed chain activity, thinking back to, we have posterior gluteus maximus, which can cause posterior pelvic tilt. If we look at these gluteus minimus and medius, which have these lateral origin to insertion, if my femur is planted and this muscle contracts, it will move me into a lateral pelvic tilt. A lateral pelvic tilt. So right side gluteus medius will give me a right side lateral pelvic tilt. So same side ipsilateral pelvic tilt, as well as femoral or iliofemoral abduction, which are the same movements. So lateral pelvic tilt and femoral abduction are the same. However, it's what's moving, which bone is moving in reference and which one is staying still. When we're in a closed chain activity, especially when the lower extremity is closed chain, the pelvis will move in relation to the femur, as opposed to the femur moving in relation to the pelvis. Especially if we're in a static position where the foot is not moving, we're not doing something like walking. But if we're locked into that closed chain position, the pelvis will have to move because it is more freely movable than the lower extremity, which is planted against the ground with gravity keeping it affixed to the ground. We'll discuss a lot of these pelvic tilts in class. Okay, so those are our gluteal muscles. Now we'll move up to iliopsoas, which is a combination of iliacus and psoas major. We kind of talk of these as a combination because they do have a similar insertion site at the lesser trochanter, and then the iliacus is attached on the anterior ilium, and the origin of psoas is T12 through L5. So our psoas attaches the lumbar spine to the femur, and then the iliacus attaches the pelvis to the femur from an anterior view. So think of it as kind of the opposer to Gluteus Maximus. These are anterior muscles with anterior origins and medial insertion, as opposed to greater how Gluteus Maximus has its insertion on the greater trochanter, iliopsoas on the lesser trochanter, which is a medial landmark on the femur. The actions for iliopsoas are hip flexion. So these are hip flexors. They're going to bring the femur anterior. They also assist with outward rotation, similar to Gluteus Maximus. So this is one case where they will work together as synergists. Gluteus Maximus is our major outward rotator. Iliopsoas would be a synergist. But this line of pull will rotate the lesser trochanter, which is medial and posterior on the femur, will rotate it medially, causing the femur to rotate outward. And then they work as anterior pelvic tilt muscles because they are hip flexors. Hip flexion and anterior pelvic tilt are synonymous movements, just like posterior pelvic tilt and hip extension are synonymous movements. So this moves the pelvis towards the femur anteriorly, as opposed to Gluteus Maximus, which causes the pelvis to move posterior towards the femur. So think of them as opposer muscles, agonists, antagonists, except for femoral rotation. Right, let's move into some smaller muscles here. We have TFL and Sartorius. Tensor fascia lata is a small superior and lateral muscle for the hip joint, and Sartorius is a superior, anterior, and medial muscle for the hip joint as well as for the knee joint. So both of these muscles have an origin on the ASIS, or so the anterior superior iliac spine, and then the insertion for tensor fascia lata is on the lateral femur and tibia, and then Sartorius on the medial tibia. For actions here, they are both hip flexors. So Sartorius, tensor fascia lata will both be synergist to iliopsoas in hip flexion. And then TFL is an TFL is an inward rotator, and Sartorius is an outward rotator. So they will work in opposition for rotation. We just talked about iliopsoas and Gluteus Maximus as outward rotators. Sartorius would be a synergist here for outward rotation, and TFL would be an antagonist because TFL is an inward rotator or an internal rotator of the femur. And then at the knee, Sartorius is a synergist for knee flexion because it does have that posterior medial insertion site on the femur, or not on the femur and on the tibia. Apologize. Okay, moving on, we have Adductor Magnus. Adductor Magnus has its origin on the ischium. Okay, so we've talked a lot about bones that attach on the ilium. The Adductor Magnus attaches on the ischium, which is a little bit more inferior and posterior on the pelvis, and then has an insertion on the medial and posterior femur, the entire medial and posterior femur. So this Adductor Magnus is a large medial muscle, also posterior muscle at the hip joint. It will cause hip adduction. It is Adductor Magnus. It's going to be our prime mover for hip adduction. It will also assist in hip extension from a flexed position, and then it will help with hip flexion from a hip hyperextended position based on its line of pull. But it will be a synergist for hip extension with Gluteus Maximus. It works as kind of the medial stabilizer, while Gluteus Maximus is the lateral stabilizer for the hip joint during hip extension. So they counteract or neutralize each other's abduction and external rotation activities with their adduction activities, so that we can have clean hip extension. Adductor Magnus is going to be a synergist to Gluteus Maximus for hip extension. Okay, next we'll talk about our adductor group. This group is made up of adductor longus, adductor brevis, pectineus, and gracilis. Pectineus is small and superior. Adductor brevis is just inferior to that. Gracilis is a long, thin adductor moving from the pubis to the distal medial femur. And then adductor longus here attaches in the medial middle of the femur. So their origins are the pubis. So the pubic bone, we just need to know it's on the pubic bone. Adductor Magnus has its origin on the ischium, while the rest of the adductor group has its origin on the pubis. And the insertion is on the medial and posterior femur. That's all we really need to know for this class, is that they are medial and posterior on the femur, anterior on the pubis. So that anterior origin to posterior insertion will give us hip adduction. They're our adductor group. They will also be synergist for hip flexion with iliopsoas and hip outward rotation. So they work similar to iliopsoas, but they have a line of pull for adduction as well. When iliopsoas cannot cause adduction, the adductor group can cause adduction, as well as be a synergist for hip flexion. So remember here, the adductor longus, brevis, pectineus, and gracilis are hip flexors, and adductor magnus is a hip extensor. So this is where they really counteract each other. They both work for adduction, but there's a group that causes hip flexion, while there is a large muscle that sits posterior and causes hip extension. Okay, moving on to our stabilizers of the hip, our deep outward rotators, which include piriformis, obturator internus, obturator externus, and quadratus femoris. These have origins on the ischium, as well as piriformis has its origin on the sacrum. And then their insertion is on the posterior greater trochanter. These deep outward rotators work to stabilize the femur. So they work similar to the rotator cuff that we talked about, the rotator cuff with the shoulder joint. The deep outward rotators work as stabilizers for the iliofemoral joint, similar to the rotator cuff does for the glenohumeral joint. So they really pull the femur into the socket and keep it posterior. The femur will often want to drift anterior because we have large external rotator muscles. When we cause external rotation from muscles like Gluteus Maximus or iliopsoas, it begins to draw the femur anterior in the socket, while these deep outward rotators can have a better line of pull to keep the femur in the socket, as well as assist in stabilizing that outward rotation and avoiding that anterior drift or the anterior translation of the femur. Similar to that anterior translation that occurs at the glenohumeral joint, similar occurs at the iliofemoral joint. So we do need stabilizers there to hold everything together. Interesting part here with piriformis. Piriformis runs on top of, or sometimes there's nerves that run through piriformis. Specifically, when we see sciatic nerve pain, or if you've heard of the sciatic nerve or something like sciatica, the sciatic nerve runs directly through or just underneath, just deep to piriformis. And if piriformis has tension, inflammation, or is overly hypertrophied, it can cause compression on the sciatic nerve. Compression on the sciatic nerve will cause pain, numbness, tingling down the posterior lateral hip and down through medial, down the leg, all the way down to the lower leg. So you may see something like Piriformis Syndrome in individuals, especially those who are constantly seated and seated in external rotation, kind of the legs are opened out, because this will shorten piriformis, and then you stand up and it lengthens piriformis. If you're getting too much tension or inflammation there, it can cause issues with the sciatic nerve. But if you have some kind of sciatic nerve pain, treatment to piriformis doesn't work, it is likely an issue with where that sciatic nerve comes out of the lumbar spine. So just because someone has sciatic nerve pain doesn't mean it's always piriformis syndrome, but it's our first step in moving up the chain to determine if that nerve issue is at the spine or if it's a muscular cause to a nerve symptom. Okay, now we're going to move anteriorly. We'll talk about our last hip joint muscle, which is rectus femoris, and then the rest of our quadriceps muscle group, which includes vastus lateralis, vastus medialis, and vastus intermedius. We talk about those three similarly and different than rectus femoris because rectus femoris has its insertion on the AIIS, which is the anterior inferior iliac spine. So just inferior to the ASIS, which we saw with our Sartorius and our TFL. So rectus femoris has its origin on the AIIS. The rest of our quadriceps group have an origin on the anterior, medial, and lateral femur. So kind of anterior, but all around, both medial and lateral on the femur. Vastus lateralis has a more anterior and lateral origin site. Vastus medialis has an anterior and medial origin site. And vastus intermedius has a strictly medial origin site. You can see here on this image on the right, vastus lateralis moves lateral on the femur, vastus medialis medial on the femur, vastus intermedius medial on the femur, or kind of through the middle of the femur, middle and medial. And then rectus femoris runs superficial to the rest of the quadriceps muscle group. And they all insert on the tibial tuberosity by the way of the quadriceps tendon and the patella. So they attach to the quadriceps tendon, which attaches to the patella. The patella attaches or moves there is a ligament that attaches the patella to the tibial tuberosity, but we call it the quadriceps tendon because the patella is a sesamoid bone that grows within that connective tissue. So that tendon really moves from the muscle to the tibia with the sesamoid bone in the middle to create additional leverage. This bone grows throughout our young life. So most babies are not born with that sesamoid bone. It develops over time and allows us to create that torque around the knee that we need to have sufficient knee extension, which is going to be the primary movement caused by our quadriceps muscle group. So all of our quadriceps work for knee extension, and rectus femoris also assists in hip flexion. So rectus femoris is a hip flexor with Iliopsoas and our adductor group. And then our quadriceps group performs knee extension. Vastus lateralis, vastus intermedius, and vastus medialis will all contribute to knee extension. They cannot be individually activated, but some can be less of a contributor. Vastus lateralis is our strongest of the quadriceps femoris group. It creates the most or contributes to about 70% of the torque for knee extension. Vastus medialis works more as a stabilizer for the patella. because vastus lateralis is much, much larger, contributes a lot of force towards knee extension, but it is lateral in how it inserts on the quadriceps tendon, which can pull and shift the patella lateral, leading to things like patellofemoral syndrome. Vastus medialis pulls the patella and centralizes it on the femur, on the distal femur, to allow for more smooth patellofemoral joint movement. So when we have issues with vastus medialis, we see some anterior knee pain because those muscles are not allowing for some smooth movement of the patella on the femur. So the patellofemoral joint does play a crucial role in that knee extension. We'll talk more about that in class. When we look posterior on the hip and knee joint, we see biceps femoris, which biceps femoris is our most lateral hamstring muscle. It is different than the rest of the hamstrings because it inserts on the lateral femur and the fibula. So it's interesting here that we have an origin site on the ischium for biceps femoris, and short head for biceps femoris has an insertion, or an origin, I'm sorry, on the distal lateral femur, and then they insert on the fibula and the lateral tibial condyle. So these will act on the hip joint, or long head of biceps femoris will act on the hip joint, and then short head and long head will both act on the knee joint on the lateral side. When the rest of our hamstrings, semimembranosus and semitendinosus, semimembranosus here and semitendinosus on the right, have their origin on the ischium, similar to biceps femoris, and then they insert on the medial proximal tibia. So we have medial hamstrings and lateral hamstrings. So medial hamstrings, semimembranosus, semitendinosus, lateral hamstrings, biceps femoris, short head, and long head. Their actions here are hip extension. There'll be a synergist to Gluteus Maximus and Adductor Magnus for hip extension. They will cause knee flexion. There are primary knee flexors, and they can be a synergist for posterior pelvic tilt or hip extension from closed chain. And they can contribute to knee rotation. So the tibia does rotate medially and laterally. So think about if you're sitting, but this only occurs during knee, or when the knee is in flexion. So when the knee is in extension, we cannot have knee rotation. When the knee is in flexion, we can have tibial rotation. The medial hamstrings will cause internal tibial rotation, lateral hamstrings, lateral or outward external tibial rotation. So this tibial rotation allows for the knee to smoothly articulate, to allow the tibia and the femur to move. If we don't have that tibial rotation, we lose some of that ability to stabilize the knee when we walk, when we run, as the feet or the tibia moves underneath the femur. We'll discuss some of like that feel and what that looks like in class. Okay. Lastly here, what does pelvic tilts actually matter? Why do I keep talking about them? We talked about them at the start. We looked at how these move. Pelvic tilts do have some major contributions to lumbar health or low back health. So what happens below the pelvis or inferior to the pelvis, what happens at the femur impacts the pelvis. What happens at the pelvis impacts the lumbar spine. So we know that anterior pelvic tilts or extension at the lumbar spine can lead to aggravations of the posterior spine. It can cause some compression of spinal nerves. It can cause the facet joints to be a little bit compressed. We also see that posterior pelvic tilt will cause lumbar flexion. So that anterior pelvic tilt give us lumbar extension. Posterior pelvic tilt will give us lumbar flexion, which we can see as compression on the anterior side of the disc in between each of those vertebrae, which can cause some protrusion of that intervertebral disc posterior, where the where the spinal cord is and where those spinal nerves are moving out of the intervertebral foramen, so that we see that we can have maybe some compression of that spine from that intervertebral disc from excessive loaded lumbar flexion. When lumbar extension, we see more of this compression on the posterior side. So neutral pelvic position can be critical to keeping the lumbar spine healthy and avoiding some of those pain. We also see it not just from a sitting position, but from a standing position. As the pelvis begins to shift anteriorly, we see excessive lumbar extension through kind of static anterior pelvic tilt or excessive hip flexion from a closed chain position, which we know can lead to issues with excessive extension of the lumbar spine. It can lead to forward head posture. We see this a lot with individuals who have excessive additional body fat. So in individuals who are obese, we see an excessive anterior pelvic tilt because there is excessive mass anterior on the body, forcing the pelvis to shift into this anterior position, which could be due to a weakness of the pelvic stabilizers. So the Gluteus Maximus as a posterior pelvic tilter is not doing its job of moving and shifting the pelvis back into a neutral position, leading to excessive extension, which can lead to excessive compression of the vertebrae on the posterior aspect, could lead to some degradation within the lumbar spine. Those discs are breaking down because they're constantly being compressed on the posterior side, with some could be some anterior bulging of the discs over time, could be some nerve damage, and this is from chronic malalignment of the pelvis, and this can be due to many different causes we'll talk about more in class. And then we'll get into how the lower leg actually influences the pelvis in our next section on the ankle, subtalar, metatarsophalangeal, and interphalangeal joints in the lower leg. All right, I'll see you for our next video. Thank you for watching.